Good evening, friends. Welcome to this critical lecture. I want to extend first and foremost thanks to Dr. Bouhadana, who has graciously agreed to join me tonight in this presentation. As you read, he's a doctor at the Jewish General and a palliative care expert amongst his other accomplishments. You've come here tonight, so you know already, foregone conclusion. Please come in. There's some chairs there. You know already that, what's the rabbi going to say? You know the Torah, Jewish perspective, we value life supreme. And in principle, I'm sure you're all aware of this as well, Judaism rejects the notion of euthanasia, or now as it's called, medically assisted dying, and we preserve life at all costs. However, it isn't that simple. First, I'd like to explain the following. So what's the objection? Somebody is, God forbid, terminally ill. It's a matter of possibly hours or days, and they're in pain. Surely it's the merciful, even religious obligation, because there is a Torah obligation to alleviate and actually eliminate, if possible, all human suffering. That's our goal. It's one of the hallmarks of the Messianic era, the perfect world, where there's no suffering or even death. So often the answer that you might hear is, well, look, in that case, it's a matter of hours or days, and the person's in pain. So, yeah, that would justify euthanasia. But it's a slippery slope. If you allow that, then what? So I'll tell you the then what. We're already at the then what. This is where things are holding today in Quebec. Quebec is the leader. 7% of medically assisted deaths happen here in Quebec, worldwide. Hang on, there's some people coming in. And so the then what now is as follows. I can read you some horror stories. Let's read you a few very quickly, because this is where things have come to. Originally, the definition was, as I just described, terminal illness, no hope for recovery, and suffering. Now, it's even reached the point the person's in perfect health, but they sign a document that if I develop Alzheimer's and I am not able to go to the bathroom, I don't want to live anymore, maybe. Case in point, this happens. The doctors will confirm this. The person develops Alzheimer's and they're happy. They're happy. They're blissfully happy. Story, actually, the family insisted this was their wish, and they killed her. She was in good health. She had Alzheimer's, but she was happy. Like she had signed the document. Moreover, now it's mental health. Mental health. For whatever reason, the person has given up on life, as the doctor just pointed out moments ago to me. So what happened? Psychiatry, suicide prevention. Who needs this? If somebody wants to die, let him die. This is now the right. And it's even progressed to children. Minors who want, for whatever reason, it could be mental or any other consideration, to terminate their life, have that right. And parents cannot interfere. That's where things are progressing. So it's a slippery slope. But again, just to illustrate some real cases, where was it here? Oh, this is an incredible statistic here. An incredible statistic. And that is that There's two tracks, by the way, without going into details. Track one, as you know, imminent death and illness, and track two is person's not going to die imminently. It's just discomfort, pain, mental, physical. A bed sore actually was a reason for someone who in the end said, it's hurting too much, it's very painful. They had a neurological disease that incapacitated them. They were in a hospital bed, developed a bed sore, and that's it, and it was executed. But listen to this, 50% of those who received MAID, this is in Quebec, cited suffering from being perceived as a burden to family, friends, or caregivers. That was the primary reason. They don't want to be a burden. 24% cited loneliness and isolation. That's what motivated them to undertake MAID. So it's a slippery slide. And again, even children. So you got to stop it. So that's it. The law would say we just can't allow medically assisted euthanasia, mercy killing, whatever term you like, because if you allow it, look what happens. This was in theory. Now it's actually happened. However, dear friends, that's not what I'm going to present today. That's not the Torah perspective, because that means that there are cases that are justified and they really should have that right to end their life. Sorry, you can't, because what can happen down the line? Why am I responsible? Where's the justice? So it isn't about a slippery slide, although that's obviously a consideration and a fact that time has borne out. Rather, what is it? Before I give you the bottom line, and it's really simple. At the same time, they said at the outset, we are obligated, and it's our obligation to eliminate all suffering, human suffering. So at the end, because I know this plays on people's mind, if somebody is very ill and suffering, and the medication that would alleviate suffering would compromise their health, morphine, in large doses, a person who is in great pain, the law is, the consideration now for their pain is what will determine the decision. And the morphine is administered even though we know it's going to compromise the heart and in all likelihood will hasten death. Certainly in a case where death is imminent anyway, we will hasten it effectively because we're treating the pain. So it's not like suffer at all costs. More about this from our esteemed doctor on this particular subject and what is available today medically. But let's understand the principle. The truth of the matter is, one lecture, you listening to me now, I cannot adequately convey the foundational principles behind why life is precious. I met a young man this morning. He coming to lecture tonight. I said, why don't you come to the lecture? I love life. Our headline was choosing death. I love life. He said, that's precisely the point. What happens when you don't love life anymore? Now you love life because life is good. When life is not good, then what? You're right. So what's the issue? What's the core? What's the foundation? It comes down to this. I just have to tell you. What is life? It's a soul. We have a soul. The soul is eternal. The soul is a part of God himself. And God wants, this is true of every human being, the soul to come down into a physical body. There is a divine mission. There is a purpose to life. Purpose to life, which reminds me to share this quote with you from Dr. Regler, who said, after he had just murdered a young man who just given up on life, and afterwards he's musing, and he says, why now? Why is it that his cluster of problems is causing you such distress, this person, where another person wouldn't be distressed. But he continues. He felt duty bound to move beyond his personal discomfort. The guy was in his 30s. Difficult life, no physical pain, just mental anguish, wants to end it. So regular confessors, the doctor, he writes this. He lives in Vancouver Island. Once you accept that people ought to have autonomy, once you accept that life is not sacred and something that can only be taken by God, a being I don't believe in, then if you're in that work, some of us have to go forward and say, we'll do it, despite this discomfort. So if there's no God, he's saying, and we have autonomy over our life, what does this mean? No God means we're a cosmic accident to begin with. We're a cosmic accident. There's no rhyme or reason with my existence. We just evolved. So there's nothing sacred about life. It is mine, goes the thinking. I don't want to experience pain. I have the right, therefore, to end it when I want to end it. That's the fact, no matter what the reason is. Physical pain, terminal illness, I don't like my boss, I'm angry at my wife, I want to hurt her, whatever the reason. Now I'm going to teach her. Now thou shalt know. So believe me, it's a motivation for people to do terrible things to themselves. So what's the foundation of that? It's my life, and I can do as I wish. So what does Judaism say? No, life is not random. Your life has meaning and purpose. Your life is infinitely precious. And what is life? It's not the physical body. Here's the paradox. It's not the physical body, and yet Judaism says the physical body's life, sacred. So it's not the body, then why is it sacred? Because all truth comes in paradox. The soul comes into the body on a divine mission. And this mission is in each individual indispensable to the all of creation. Every human being is the whole world. That's what our sages say. Why God created the world, he created lots of birds and bees at once, and lots of ants and elephants. But one human being, Adam and Eve actually were one, and they separated it. Because, what's the reason? Because every human being is obligated to say, the world was created from me. And that's true. For God, you are everything. And your soul comes down to the world in order to contribute the unique mission that only you can do and nobody else, and your life is infinitely precious. But Rabbi, goes the question, what about someone that's born, God forbid, a child that's severely compromised mentally, physically? What purpose? What purpose could there be of a terminally ill patient in a hospital? They're just a burden. You heard what 50% said, I want to be a burden on family, on society. Doesn't Torah say, goes the question, that we may not waste resources? That's a very important thing. When your mother told your grandmother, don't waste your food. Don't wait. This is a big Torah principle. Nothing's to be wasted, ever. It's God's world. Everything has a purpose. So here all these money and resources in the bed. Studies show that at this point the government is saving. No one's saying this. There's a reason, a motivation for MAID and the legislation on the table now again for children to have that right. It's $150 million a year, and it's increasing as the number of MAID cases increase. So it's wasting resources. No? Goes the question. What value could there be in that life? So this requires really, to understand this, a proper study of Jewish spirituality and ethics and the soul and before life and after life and reincarnation. It's all part of it. But I'll try and convey to you simply one scenario that you'll appreciate that will help us understand what value is there in a life where the person can't golf, can't do anything. Severely handicapped or again, terminally ill and in a coma, on a respirator. What's the value? So here's just one of infinite possibilities, infinite reasons why this soul still needs to remain here until such time that God will say, your mission, at least at this stage in your history, because we have a history. We're not here the first time. Yes, reincarnation is a fundamentally Jewish concept that others took from us. So it's God in the end that determines when. At the same time, entrusting us with all the obligations to alleviate suffering, which again details more later. But to address the question, so what's the purpose? So one of infinite possibilities. Somebody passed away. Come to the heavenly court. Yes, there's a heavenly court. The heavenly court is we face our lives before God, which is the truth. So again, one of infinite scenarios, and I'm making it very extreme just to make the point. This was a person during their lifetime, did a tremendous, incredible amount of good. So much so they're always doing for others. Never let you do anything, I'll do it for you. Children, spouses, community, which is wonderful. What greater virtue could there be? This person giving and doing and doing and doing and doing. The person passes away, comes before the heavenly court. Again, just facing God and the truth. And this is what emerges. When we die, friends, we don't go anywhere. We just face the truth. The unadorned truth. And that is our mission here in the world is not only to do. That's part of our mission. Perhaps even a greater mission is to inspire or elicit doing, giving sensitivity in others. So the heavenly court, as it were, determines this soul comes back to the world. Do, you've done. That's not your mission now. You're going to be, this soul comes into a body where it cannot do anything. But what? It's eliciting all of this unconditional love in an extreme case from so many other people. Ennobling the world, helping them fulfill their mission as the soul completes its mission. So someone's lying in a hospital bed and on a respirator. What's the effect here? What should be the effect? The family, maybe one less vacation because they're sitting by the bedside, unconditional love, holding their hand. What holiness is revealed in that moment? Unconditional love and devotion. This person's ennobling these lives. They're not so indulgent and selfish as we naturally would be. Because here's someone that we're there for, they can't even give us a smile back. That's an incredible revelation of holiness in the world, part of that soul's mission. And their mission is also to bring that out in me. So I have to know the responsibility, I have to respond to this. And if it gets complicated, if I don't, there's reincarnation. That story will continue until we get it right. So one of endless examples. Why would a soul, what's the mission? What's the soul doing? That doesn't define the value of life. There's no such concept as quality of life. Every life is infinitely precious. No more, no less. Every life. So again, what's the soul doing here? The other possibility is one of infinite possibilities. Sometimes this is very mystical and you need to learn a lot to appreciate this. We try and teach it here. The soul simply has to occupy the body for X amount of time to fulfill its mission. Just being in the world. The soul being in the world radiates holiness because every soul is holy. Just being, whether anybody visits or not. But they're certainly affecting nurses and doctors who are giving altruistic care. But even if that wouldn't be the case, just the soul being in the body is holiness on earth. You see, the whole purpose of life, is God wants us, souls, to come down into bodies to sanctify the body and the world, to reveal holiness here in the world. Just by being. This soul isn't certainly sinning. It's pure. Just by being, this soul radiates and brings holiness to the world and sanctity to the world. And that's infinitely precious. Yeah, the big concern is pain. Nobody wants to suffer pain. So a few words about pain. Number one, as I said earlier, we, doctors, others, family, we are obligated to see that our fellow human being, certainly family, does not suffer. And we have to do everything in our power. Governments debated for decades whether to allow medical marijuana or heroin or other drugs. From a perspective, it's not a discussion. If this can help you, use it. That's why it's there. There wouldn't be a discussion that any drug that exists in the world that can help alleviate someone's physical pain has to be used. I said that if the drug is going to compromise health, so that every situation has to be discussed on its own. But in principle, if certainly a terminal illness, the drug is to be administered to alleviate the pain. So that's on the one hand. We do everything we can humanly and every discovery to alleviate and actually eliminate altogether all human suffering and pain, physical and certainly mental. I mean, again, that whole discussion that I'm not elaborating, but mental pain is a reason for made. What is he saying? Judaism says nobody's beyond redemption. You can help this person. This person can be helped. This person needs love. This person needs a supporting society. This person needs to understand that their life is meaningful. That's what they need. Not a lethal injection. And tragically, so often people don't even know that this is available. We'll hear more about this from the good doctor. But back to pain. So first of all, we do whatever we can to alleviate it, and it's not what people today, modern science, you'll hear it. It doesn't have to be ever almost a painful death. But there's something else you need to consider. God runs the world. Everything has a purpose. If after all is said and done, we try to alleviate the pain, and it still persists, there is a reason for that too. I'm going to tell you something about my grandfather. Well, I just found out, blessed memory, his birthday is Sunday. Friday, test history. The Bisa Kluvland. So my grandfather in Australia, I was already in American yeshiva, in his early 70s, was diagnosed with a very aggressive throat cancer. My uncle tells me, Uncle Mendel, actually he shared this with the family. So he accompanied his father to the doctor after all of the tests. And the doctor tells my grandfather, Rabbi Klufgan, it's aggressive, and I told him there's a very short lifespan, short time to live. My grandfather's not reacting. And they finished and walk out. So my uncle says, his son said, Yiddish, he speaks, did you understand what the doctor said? Maybe you didn't understand. He spoke a very good English, mind you. And he was a great scholar, right? He said, yeah, I understood. So my uncle is kind of silent, and my grandfather continues, we must accept everything with joy. These were his words. And never complained. My mother passed away from the same illness. Never, ever a word of complaint. And why me wasn't on the radar. She would console and comfort us when we'd come to visit her, my mother. My grandfather wasn't there when he passed away. But his response was, these are the words quoting our sages, that we need to receive everything, even suffering, with joy. Now, how could this possibly be? Yeah, it's a big subject, but it has to do with many factors: reincarnation, cleansing. What we're saying, friends, is that everything at the end of the day is for what happens to us is for our good. It's part of our personal journey. It's part of our personal journey. And after our physical sojourn on earth, and the soul looks back at what the soul endured in the physical body, it's grateful for it. What a way to live, friends. Just forget the theological considerations. What a way to live, where everything that happens to you accept lovingly with joy. This is not a passive way. We do everything we can. Again, we're obligated to do everything we can to end suffering and help ourselves. We're obligated, friends, to be healthy. This principle, the body is not mine, the soul is not mine. It's not mine. We don't have autonomy. I didn't ask to be born. What do you mean it's yours? You asked to be born? Where'd you get it? Where'd you buy this body? It's all a gift. And there's a purpose and sanctity to life. And part of that is also to be healthy. It's an obligation in Torah law. There's a whole discussion amongst the contemporary scholars about smoking. Is it permissible according to Jewish law to smoke? And the consensus is no, because it's injurious. It's a sin. Why? Because we are obligated to care for the body, which means it's a mitzvah to eat healthy. It's a mitzvah to rest enough, to exercise. These are obligations. Why? Because the body is not mine. It's created by God. The soul is also not mine. It's a piece of God that God has expressed and now has become me, and it's invested in this body, and it's all sacred and purposeful. And every moment is infinitely precious. Every moment. I just read an incredible story. I have it somewhere. This is in the Kovna ghetto during the Holocaust. And the Nazis were just about to burn the hospital with all the patients alive. A famous rabbi, his name will come to me in a moment. Anyway, so he's telling his students, look, I'm old, and he was terminally ill also. He said, you're not, your time and energy, you get the other patients out that can still have a chance to live, get them out of the hospital, leave me here. But one thing he said, just take me to the top floor. If there's time, take me to the rabbi by the top floor. Because the flames will get there a little later, and I'll live a few seconds or minutes longer. Because every moment that's possible for the soul to be in the body is sacred, is a mission, is emitting holiness, and part of the reason why my soul came down to the world. So if you can't, not meant to be. But if you can get me there, then I'll die a minute later. My soul will be in the world a minute longer. That's how precious every moment. We do everything we can for another moment of life. Why? Because it's divine, it's sacred, it's the reason the soul came to the world, and the whole world needs this person alive now for as long as possible. So God therefore will decide by orchestrating things that the person's physical life is over. So again, you must be thinking, what about all these lives that were snuffed out earlier? All the maids, all the suicide, euthanasia, reincarnation. That soul's going to have to come. What God has is come back and, complete a life that was incomplete. And that's not easy. The soul doesn't want to do that. In the end, what you're hearing is, it's all meant to be, and all souls in the end will fulfill their purpose. But our job is to do that fluidly, happily, joyfully, healthily, as much as we can. Okay, I'm going to ask our doctor to share with us his experience and some of the issues that you might have, and he has a PowerPoint that I'm sure you're going to find interesting. And then we'll open up for questions. You'll ask. I can't hear you. My wife will, and she'll tell me your question. Dr. Bouhadana.
So thank you so much, Rabbi New, for inviting me. I'm very, very pleased to be here tonight. I see some familiar faces. It's really nice to have such a beautiful crowd tonight. I just want to acknowledge the presence of some of my colleagues at the hospital, actually, working with me in palliative care. So it's amazing to have some support from a social worker, Vivian, and my colleague. Actually, he's not Jewish, but he's very ingrained in spirituality himself. This is Thomas the Gabori. He's a gibor, because that's his name. So it's amazing because we share a lot of the same values. So I wanted to acknowledge his presence tonight. That's a very great support. And some of you I also know. I do have a presentation that I mean, this is something that I've been invited to speak about before. It's more let's say the made versus the non-made, right? It's the palliative care world versus what we're faced with now, which is the request for made, which you've been presenting. But I don't know. I don't think I'm going to use the presentation. After hearing your speech, I think I'm going to just share with you some real life cases, okay? Because right now we spoke about the soul. We're really, talking very high spirituality. So I'm going to try to bring it down to, right here, what's happening. A lot of people have questions, and I had the question listening to you. I don't know if you can hear me, about suffering. So suffering is one of those things that people are afraid of. This is why this is happening, is we ask our patients, are you afraid of dying or are you afraid of suffering? And the answer almost exclusively is always a fear of suffering. There's multiple fears that patients have, even if they're not at the end of life, just being ill, being sick, having a diagnosis, any diagnosis. It could be a diagnosis of chas v'shalom, something very, very serious. But even if it's not, going through tests, having to have to do investigations, anything creates that anxiety and that fear. Maybe I'm going to have something, okay, that's cannot be treated. How my life is going to change. The fears are huge. The anxieties are huge, based really on suffering. Although at this moment I'm not suffering, the idea that I might one day suffer is something really difficult to live with. And when you're faced finally with the idea that your life is coming to the end, somebody's life is coming to the end, the fear of dying seems not to be an issue. Am I right? The fear of dying itself seems not to be an issue. It's the suffering, that the process, that motivates that person to want to try to say, like, okay, can't live with this, I need to end it. And it's an unfortunate thing that we have experience pre-made, and we have a new experience post-made. As far as palliative care is concerned, I would say it's not a popular thing. It's never been a popular thing, but we've been able to save people from made multiple times in the past, and now it's becoming much harder. It's a much harder thing to go and try to convince people that there's something else that we can offer, that there is a way that we can hopefully help you through that suffering. It's a daunting task. And I'll tell you a few experiences, a few patients that I've been involved with. A good story first. This is a few years ago. This is pre-made. Okay? This is a lady who was diagnosed with a cancer. She's a very, very well-respected lady. Her name I won't mention. I remember her. She was an author. She liked to write, very artistic, high in society. She loved to go in the Gaspé region to spend her summers and reflect on life and be able to write. And she found herself suffering through cancer, treatments, not being able to do such. And we were consulted from palliative care, the Jewish, by our colleagues in oncology, to come meet this lady one day when she was visiting, came back from Gaspé. But now she had decided this is pre-made. We didn't have made here. The only place anybody could go at that time to have euthanasia, okay, this is the real term, we have to say it, okay, blankly, to have euthanasia was to go to Europe. And she was ready, she had bought her ticket, and she was off to Switzerland. That's it, I want to end it, I cannot live through this. She had pain, but let's say, I mean, I can't judge, we're not here to judge anybody's pain, but relatively speaking, for other patients that we've seen, I would say it was mild to moderate. Okay, this is my assessment in terms of, but for her, of course, it meant that it was the end of her life. She wouldn't be able to bear. And the idea that her life now would be one of from independence to dependence, right? It's like it's changing, your life is changing. You're not autonomous anymore. You're losing your autonomy. And that idea was not something that she was able to live with. So that's it. She decided she's going to Switzerland. She had her ticket, she showed it to us, it was done. Nothing we can do. Myself and my nurse went to visit this lady, and we spent 2 hours with her. In the end, she managed to say, okay, I'll give you guys a chance. We presented the idea of palliative care. This is what we do. We can try to help to alleviate your pain, your suffering. Give us a chance to be able to see if we can get somewhere with you. And I will say that we succeeded. This is a non-Jewish lady. She, in the end, accepted the morphine, the medications to control the pain. And eventually she needed to be admitted on our floor on palliative care, and she passed away there. But for the time that she was there, she was a sunshine, a ray of sunshine on that floor. This is before, I guess you were there, maybe. No, Vivian, I think you were there. She wanted, what we do on palliative care, we try to create an environment that's, for the patient as comfortable as possible. So they need, whatever arts on the wall, any colors they want. She loved to have a lot of her own dolls. She had a collection of dolls. So she turned the place into this beautiful sanctuary for herself. And she was smiling all the time, thanking everybody for helping her. And eventually she passed away, but she passed away in a very peaceful and I would say healing, way of passing, as opposed to when we had seen her before and that's it. The life was ended. She was gonna. So we saved this lady from euthanasia, non-Jewish. This is the good story.
What is palliative care exactly?
I will get to that. The not so good story or the tragic story is a Jewish patient. Okay, and I think that's why we're having this tonight, because more and more Jewish brethren are asking for maid at the end of life. This is a reality. Okay, I don't have one story, I have several of them. The one I'm choosing now is because this is a religious Jewish patient that I was involved with, who I get emotional when I tell the story because it was a real fight to try to convince this person not to go through it. He wasn't diagnosed with any terminal illness per se. There was a lot of comorbidities, we say, in medical terms. A person has multiple ailments, diabetes and complications and other problems, chronic pain in the back, kidney disease, failure, not on the dialysis, but a lot of different, comorbidities together that created a person who felt that their autonomy had diminished quite significantly and was suffering. And he said, that's it. The medical system has failed me. This person was hospitalized for some acute decompensation on our service. I'm also a family doctor, by the way, so I also do family medicine at the Jewish General, the Herzl. If you've heard of the Herzl, I work there, I'm a staff there. I do palliative care on the side about 40% of my time. And here I was involved more as a family doctor for this patient who was hospitalized. I knew him from before. I knew this person for a long time. The reason for that is his dad was a patient of mine. Just in family medicine, his dad passed away. And I would still see him once in a while after he had passed on. And we would sort of reminisce about his dad. And he would always come in when his dad came. He was an elderly gentleman, and he would be present and we would sometimes cross paths in the hospital, say hello, and so we had sort of a relationship already. When I met him on the floor, I asked him, I begged him, I said, give me a chance to help you. He did not want. And there was no way to convince this man otherwise. We brought community members, we brought rabbis, we explained it to him, the Torah values, life is so precious. There's no such thing as quality of life, okay? Like, but his quality of life, perceived quality of life, had diminished so much that that's it. He didn't want to go through it anymore. He didn't want to live anymore. And there was no question that there was anything that I can even offer this man. And in the end, he opted for MAID, and MAID was offered. Not because he had a terminal illness, just because the suffering was so hard that he was deemed a candidate for it. Okay, and that's a failure of palliative care. This is, of course, because it was available here. I think it's a failure of society. It's a failure of medicine to see these patients. Now, if that's my stance, because I'm against MAID, of course, it's not something that I propose or that I would actually want to opt for, not for myself, not for any patients, not for any families. So presenting palliative care, and I'll give you what that means, is the other option, hopefully the better option. So what is palliative care? Palliative care is the kind of care that we offer our patients who are suffering, who are going through difficult times with their disease. If you want, we could sort of separate. There's two things. There's disease-oriented approach, right? There's somebody has a disease, we give treatments, prescribe medications. Somebody has cancer, chemotherapy, and then there's the patient-centered approach. Right? So palliative care wants to be more of a holistic type of approach, looking at the patient, looking at their needs as a person. But this goes together. Right? You can't separate the two. So while the oncologists, for example, prescribe their chemotherapy, and somebody has to go through the treatments, and hopefully, B'ezrat Hashem, they should be, successful and cured. But if it happens that it doesn't work, but even if it does work, there may be some consequence of the treatment. And so palliative care wants to help those patients, help the symptoms, help with comfort, help with pain, any other consequence of the treatments, whether the treatment works or doesn't work. There's a continuum of care. Okay? We think today of palliative care as treatment phase, and then finally there's no treatment anymore, failure of treatment, patient is considered palliative, quote unquote, so now let's call in our colleagues in palliative care. Okay? That's not what we want. This is the reality of how things are happening today. A lot of times, palliative care is the enemy. When we hear palliative, we think end of life. Nobody wants to hear about their end of life. Everybody wants to hear about the cure. We want to be able to go through our treatments, successful treatments, and go on with life. Put it behind us and go on. This is the reality. And this is what we want, and this is what we pray for all the time. But sometimes it fails, sometimes it doesn't work out. And then we don't want to abandon our patients. So the fear of abandonment, I was talking about fears. Fear of abandonment is another one of those fears that's important. And we're there to be able to accompany those patients. You don't want to hear from your oncologist, I have nothing else to offer. And then what, right? What do you do? The oncologist, they know what medications to prescribe for such and such a disease. When the disease doesn't respond and I have nothing else to offer, it used to be, okay, before, that's it, you're on your own. What do? You go to your doctor, your family doctor, if you have a doctor, what do they do? So palliative care was born out of that fear of abandonment, that there's nothing else to do after. No. We palliative care physicians say there's always something for you to do. We change the approach. If it's not cure, it's going to be care. We're going to care for you till the end. Make sure you're not abandoned. Make sure we allay those fears. Make sure that your symptoms are controlled. There's no hope? No way. There's a different hope. We have to reframe it. We never want to lose hope. We never want to make sure, always want to make sure that somebody's hope is still there. There's hope for better quality. There's hope for, accomplishing what you were saying. It helps to get the caregivers together. So what is the purpose of somebody's suffering? You answered it right. It's everybody getting involved. It's the good that we can do. It brings out the best in us to be caregivers, to be able to assist. It's a teamwork. And that's what we do in palliative. We try to get everybody involved. Nurses, social workers, physios, OTs, family members are part of our team to help the patient through that. So that's in a nutshell what palliative care wants to do and successfully achieves if we're given the chance. And that's something that we're seeing we're losing more and more, the battle against MAID. Okay? MAID has sort of taken over a little bit. I'll tell you here in Quebec, I don't know how it is elsewhere. MAID was introduced in 2015, okay? 10 years now. The moment that it was available, we see numbers soaring. Number one in Canada, Quebec, in terms of the numbers of MAID requests, and of course, requests that were actually completed. Some people do change their minds. The number one reason for MAID, you did mention it, is not pain. It's not physical suffering. It's much more the loss of autonomy, the loss of dependence, and the fear of what comes with that. Losing your dignity, quote unquote. Okay? That's usually the number one reason for MAID requests. The second one is often being a burden on the family. I don't want to be a burden for anybody, nobody, which is contrary to what you were saying. It's not being a burden. It's actually, the family is, and you ask the family, of course, they never think that it's a burden to take care of their family members, but it might actually be the purpose of that person's suffering to be able to bring these people together and have them create that chesed, the care that they can bring, that they can do, and towards that person. But that's usually what happens. People are afraid of being a burden. They're afraid of the suffering. They're afraid of losing their dignity and losing their independence. The physical suffering, the pain is there, but it's usually number 4, 5, or 6 even. Yeah, I have a slide on that I can show you, but I tell you it's the same thing. And so, yeah, so what I wanted to say about Quebec is that you would expect, and it is in the law, okay, the law that came out, initially, it was supposed to be palliative care that was going to be administering part of the end of life, the act respecting end of life, they call it. Okay, this is the law. The act respecting end of life, meaning now people have a right, of course, for a lot of things. We have a right to choose who we want to care, who is going to care. We have a right to refuse treatment, multiple rights. But the main right that came here is the right to die. Expressing the right, my right to die. Because why? Because it's my body. I can choose what I want to do with it. Therefore, I can express my right to die. And expressing my right to die means, for the government, when they created the law, means, yeah, you can die either through MAID or through palliative care. So palliative care was going to be the one to administer the end of life, whether it be the comfort care or the MAID. And at the time, 10 years ago, if there was one most vocal organization, or the people that were the most vocal, and I usually use that in my presentation as well, was the palliative care physicians. Okay, it's not going to happen on my mandate. Would be some people would say directors in hospices. If the law passes, it's not going to happen here. Palliative care, it's contrary to the values and the principles of palliative care. Palliative care wants to improve quality of life, maintain life till the end. The end will come, but in the meantime, we want to make sure that we're respectful of the dignity of the patients, make sure that their symptoms are well controlled, without hastening their demise, without accelerating the process. The process will start, is inevitable. Death is part of life. That's a reality. Until that moment, we make sure that the patient is well taken care of. You have a question? Yeah.
But if you give morphine,
Okay, good. So if we give morphine, what happens? We kill them faster, right? Okay. So all studies, one after the other, okay? Halacha, we just heard the halacha, Jewish law. Okay, Jewish law says somebody is suffering, we want to treat them, we give him medication. Okay, the Tzitz Eliezer is the one who wrote a beautiful responsa. Tzitz Eliezer, Rav Yehuda Waldenberg, beautiful responsa he wrote. Somebody is suffering, and we have life-saving medications and morphine to treat their pain. You go with morphine to treat their pain. Of course, if they don't want the life-saving medication because it's going to prolong their suffering. If the patient says, I don't want it because it's going to prolong my suffering, you give them the morphine to control their pain, even if we know that it's going to accelerate their demise. This is how he writes it in his responsa. But what he's saying is, I guess, beautiful because it allows us to treat the pain. But what he's saying is wrong. Because time and time again, if it's well given, morphine and all the other opioids, if they're well given, and they're given in a way that is controlled, we do this every day. This is our job. We do this. I've been doing this 25 years. Okay? We don't kill patients. We don't kill patients by giving morphine. It's not true. It's one of those fallacies, one of those things that, of course, is in the belief for centuries that morphine at the end of life means we're going to kill a patient. Experience tells us that no, it's not true. In fact, palliative care, okay, you'll be surprised to hear this, prolongs life.
So what is made?
Okay, good question. So people think, you're right, that MAID is done through morphine, right? Is that what your question is? Or so medical aid in dying. Medical aid in dying is what we're talking about. MAID, medical aid in dying, means that somebody who requests to end their life is granted if they're found to be if they're found to be candidate. So if I go with the law, the way it was stated at the beginning, okay, because now the law has slipped into this slippery slope, but the initial was a patient is suffering, they have a terminal illness, they're suffering too much, it's felt that there's no other options for them that could help them beyond the treatments that were already given, then they can exercise their right to die and ask for MAID. They have to go through an evaluation with two doctors to evaluate whether yes or no they're candidates. They have to be the ones asking for it themselves. The patient themselves have to say, not a family member, not a parent, not an advance directive. This is the original law, talking the way it was written at the beginning. Okay, not an advance directive. Those things have changed since. Okay, and what do we do if they're found candidate? Then it's a doctor who gets medications. 3 medications usually. One is a sedating medication. It could be propofol, for example, or some other medication that is like an anesthetic, general anesthesia. And now the medication that is used it's called rocuronium. It's a curare derivative. Curare is a paralyzing medication. Okay? You give curare to somebody, you paralyze them, and it stops the heart, stops the breathing, and then the heart stops. But they're sedating. We sedate the patient. Of course, they're not conscious throughout the process, but it's a lethal injection that is given.
Capital punishment. They stopped that. They said it's not.
Okay.
It
So
doesn't work anymore.
no, but it works very well. Okay. This is the procedure, the way it is right now. Okay, there's medications. Now, morphine doesn't appear in that. Okay, morphine is not given. Many times, I've asked the questions like, "What do you think we give for MAID? Like, how do you think we kill people Right? This is exactly what's done." The answer every time I get this question, I ask, it's morphine. We give morphine, high doses of morphine. Okay, studies after studies show that morphine is the worst medication to give for this because, first of all, they suffer much more through it. Okay, from the morphine if it was given in high doses. So morphine is only going to it might be given as an adjunct if there's pain, which usually there is. So it's given as an adjunct. Okay, the way it's given is and it's not necessary to give morphine for that process. Okay, I'm giving it to you crude there. Okay, this is the way it is. it's a lethal injection given by a doctor. It could be done in the hospital. It could be done at home. It could be done, of course, in a hospice. It could be done in a long-term care facility, Hospital Maimonides, for example. Every institution in Quebec has to have the service offered. The Jewish General Hospital, when the law was started, said, not going to happen here. But we were forced to do it, to impose it, and the direction had to ask who are the doctors who volunteer, and doctors have volunteered. Now, the tragic story is I gave you the patient who, Jewish, is not the only one, but the tragic story is a lot of these doctors who do it are themselves Jewish. Okay, so we have Jewish doctors who are administering MAID to Jewish and non-Jewish patients. Okay, it's become a tragedy, unfortunately, as we see it, and yes. So why I'm here now is to not talk to you so much about the tragedy. I mean, to explain the tragedy, but introduce the idea of palliative care. Okay, and how palliative care wants to try to change that and introduce an idea. And in Quebec, you would think the law would have included palliative care as a mandatory first step before going to MAID, but it isn't. At the beginning, it was supposed to be palliative care to administer it. They understood that palliative care did not want that, and it was against our principles, so they separated it. Palliative care would still be a law. It's the only place in Quebec, actually, the first place where palliative care is legal. Okay, has been given a legal status, but we're competing with MAID. So somebody who's requesting MAID, we would have thought would have had an automatic palliative care consultation. Perhaps we would be able to be involved here, convince them otherwise, offer the care that we say we can offer, and perhaps not have to go to MAID, but it doesn't have to be. And a lot of people are not given access to palliative care. And that's a general question in and of itself, even pre-MAID, access to palliative care.
Would you be able to clarify what you meant by palliative care having a legal status?
Yeah.
I'm not quite understanding.
In the act respecting end of life, okay, the way that it's written by the government, palliative care has been given a legal status as as an option, okay, it's not just a medical, it's part of the law, okay, of end of life care, that palliative care is part of the law. That's what it means.
So they have to go through it.
There's a legal right to palliative care, yes.
Meaning that they have to go through it?
No, so
No. Meaning that it has to be offered.
it does. That's it. So it's a bit contradictory because it's not being offered when somebody is requesting for MAID. It's not automatically being offered. You would think that the request for MAID would include a palliative care consult, but it doesn't need to be. One at a time.
Seems to indicate during your presentation that you find that MAID has progressed to a point more than what you first expected in 2000.
Yeah.
Am I to understand that correctly?
Yes, the numbers are crazy. The numbers of MAID.
Because the law respecting MAID has been modified, or it's because people are just choosing?
People are choosing.
And the law remains the same?
So the law has changed. The law has changed. The only change that happened is the slippery slope. Rabbi New mentioned that. Now you can put an advanced directive, okay? Meaning, I'm in perfect health right now, but whoa, chas v'shalom, I should have Alzheimer's. Well, the living will, exactly. So somebody can have a living will, but you can put it in your living will that I would want MAID if I'm in that situation. Before, the living will usually is more for withholding certain things. I don't want to be intubated. I don't want to be on a respirator. I don't want to be given chemotherapy or dialysis. Usually it's to limit things, a living will.
Therefore, the law has changed or modified.
Has been amended, yes. There's been some amendments over the time. That's why we were saying there's track 1 and track 2. Track 1 was terminal illness only. Now it includes other reasons that are not terminal illness. That's track 2. Somebody could be on track 2. They don't have a terminal illness. They're not dying from cancer or from end-stage heart disease or something that is considered terminal end stage. They could just have uncontrolled suffering. That was the case of my patient. Okay, the second patient, the Jewish patient I mentioned to you, he was a track 2 patient. Those are patients who can ask MAID outside of a terminal illness. Okay, that came into depression. Mental health is starting to get into that too. Existential suffering, yes, could be included in that. And then now, the new thing since October 2024, I think it's October that it came into law, is the advance directive. So putting a living will, putting it into living, would want MAID administered if I find myself in such and such a situation. You can write it in advance. Right now, I'm fully able, I have no illness whatsoever, but I cannot live with myself in such a situation, so please give me MAID when it happens. Yeah.
Is there any benefit to it? Is there any benefit to it besides monitoring it for your stored money?
Isn't it?
Is there any
Benefit
to society?
To society.
To society besides
So,
monitoring?
yeah, so
It
okay.
doesn't make sense.
I mean, if you look at if we look at cost of end of life cost is huge. Okay? Cost at the end of life is huge, for sure. There's savings from that perspective. Okay, is that the motor? Is that the motivation behind it? No. Okay, I don't think that's the motivation. I mean, something that was available in Europe and other places. How did that law come about? All the details and the discussions that took place and the requests. Let's say that MAID always existed, okay, illegally. Okay, I can name you Dr. Kevorkian and others, and we know that it's happened at different levels. I've seen it myself in our hospital, and we know that it's administered by other doctors. It used to be that it was morphine drips that would, go up. So it wasn't done in the most clean way, but did it exist? Yes. Okay, undercover, and unfortunately was there. So it's like legalizing marijuana, if you want. But it's not the same thing, but it's the same idea.
Why don't we hear more agendas, more people speaking against it in all the Jewish community, large, more PR?
Yeah, so I can tell you that I was invited to speak about this not long ago, just next door. Okay, Dorshe Emet, they had a similar event, and I was invited to speak about this as well. So we're trying to yes, I was invited also at the Cumming Center to talk about end of life issues. Those are real issues. People don't want to hear about their end of life. I mean, who wants to hear about your death here? You're not here to hear about your death. You're not thinking about this. But eventually, death is a reality, and so we have to educate our population that MAID, Jewish law, is against MAID, and we have alternatives. Yes.
Why do you think that money is? I think that's the leading reason why the government would choose not to present palliative care, because palliative care might mean 6 months, a year and a half of being.
Yes. End of life care costs a lot of money. Okay, palliative care costs less than somebody who's on ICU. A lot of patients die in the ICU, die in an emergency room. They die on very active medical floors. So if we promote end of life towards more palliative care, we would save money compared to that. Of course, if the patient dies earlier, then it's the same thing about cigarette smoking. Cigarette smoking should be banned. We know it kills people. We know it causes cancer, but it's a huge amount of money that they make off of it, and they save because people live shorter lives because of it. But is that the motivation? It's a secondary gain, I would say. Okay, I mean, it's. Eh?
Let's say there's a question if she's waiting for a long time.
Sorry. Yeah. No. Maybe somebody should look at the fingers, because I can't look at everybody. Go. You're next.
I want to figure out how to ask this. First of all, thank you for your excellent presentation, both of you. But thank you, Doctor, for putting it out there as it is. My question is the following. You mentioned that within at least the Jewish general, there are many doctors or certain doctors that stepped up, and you mentioned that they were Jewish doctors. I'm actually curious what your conversation with those doctors is like. My real question is, if they were here presenting,
Yeah.
what would they be saying in terms of why they're assisting patients? And the bottom line is, does it have to do really with how spiritual they are? Sorry.
No, it's a very good
It's
question.
really my question.
I mean, of course, I'm biased, right? I mean, I've, like we discussed this. You want the both sides of the coin. There's always another side of the story. I can tell you because it's happened before, and there are presentations that have been made in the hospital. Okay, in terms of that these doctors present made according to their own practice and expertise that they've developed through this. The fact that they're Jewish is tragic, but yeah, so they're not practicing and may not. And if they were to know what we're discussing tonight, would they change their mind? Probably not. Okay, it's all based on autonomy. Medicine is a science. So we're doctors. We're trained. We learn about the science. And one of the bigger ethical issues, like ethical principles that we go by, doctors everywhere, Western society in particular, okay, is autonomy. Autonomy trumps everything. Okay, so patient autonomy to get consent to do. We can't intrude in people's lives, no matter what Jewish law or any other religious or any other type of group might say about autonomy, because for sure Jewish law says we do have autonomy, but it's not the same. Okay? The autonomy is we forego part of our autonomy to halacha in Jewish law, but autonomy in any ethical dilemma. An ethical dilemma is a conflict between two values that compete each other. Okay, so the principles are like this: first, no harm. First, do no harm. Second, do good. Okay, to do good, justice, social justice, personal justice, under principle, and autonomy. So if I'm going to do, I might, if I might cause harm by wanting to do good at the same time. Okay, that's what you call a double effect. There's always the question of a double effect. Is at the same time that I want to do good, I might cause harm. Okay, that's a principle in wars, for example. You want to eliminate the enemy, but you know that there will be some casualties. How do you balance the two? Okay, so there's a conflict there. So if there's a conflict with autonomy, autonomy trumps it. Okay, that's the science. That's the ethics in general that we go by. And a patient has a consent, has a right, and we can't intrude into that. And that's why these doctors who do this, they sort of remove themselves a little bit. It's not me. The law allows it. Patient wants it. No problem. It's a treatment. The same way as I write a prescription for antibiotics, chemotherapy, or I take a patient to surgery, it's considered a treatment. So these doctors have no problems ethically, morally, to be able to do this. They'll go further than that. Their presentation is going to be a celebration of life. This is what they'll tell you. Okay? I heard it myself, and they would stand here and say, it's a beautiful thing. It's a beautiful thing made. Families get together, they choose their date, the patient is peaceful in their bed. You feel, and it's true, I've seen it myself, that there's a sort of a relief. Okay, there's like a type of a relief. The decision has been made. Everybody's around. Everybody's present. Everybody's saying their goodbyes, holding hands. Of course, there's going to be some crying, some tears, but the patient has reached a level of healing. You know what healing means? It's a spiritual. It's not. There's cure. When you want to cure a disease, but a spiritual level of personal healing. You feel you're in a peace with yourself, you know where you're going, and there's something beautiful with that. And that's what they'll describe. And we've heard families been invited whose parents have had made, and I shared the story before with my colleague here, or her colleague, a colleague of ours who used to work in palliative care, was diagnosed with cancer, who opted for MAID. She was a social worker at the Jewish General Hospital, herself Jewish. And I wasn't involved in her care trying to convince her otherwise, but listening to the family and how it, it's like this is the most beautiful thing you can imagine. So it's attractive. It's attractive. No suffering, peaceful, everybody together. Imagine the scene. It's, you know what euthanasia means? It means beautiful death. Euthanasia, the term euthanasia, that's what it means. It means a good death. Mita yafa. We see that in the Gemara. It says mita yafa. It's in the Torah. A beautiful death. That's what it means, euthanasia. Really, that's the definition, original definition. So this is what it is. People want a beautiful death. So you can choose that now.
Just so I understand.
I just want to make something clear, because that was made earlier. Very stark from Torah law, God's law. Euthanasia is murder. It's murder. Suicide is also murder. This is the most grievous sin possible, which means the most grievous damage we are doing to ourselves and to the one we murder, that they will have to face in the afterlife. Just without quoting this. So they make it very attractive and it's beautiful. I just read an account of an elderly couple that were holding hands and were given a lethal injection, and they wrote how beautiful the death was. From the Torah perspective, that doctor is a murderer. It's a capital offense. And in theory, it's a crime in itself. It warrants the death penalties. Do it for many reasons, by many halakhic reasons. We just should know that. Made is murder. Euthanasia is murder. And signing such a document, even withholding medication that could save a person's life, is murder. Pulling a respirator, withholding food because nutrition, because the end of life, what's the point? In Torah law, that is murder. It's just really serious stuff.
Yep.
Yeah.
There's one behind, sorry. Yeah.
Just come back to your field of expertise, okay?
Yeah.
Both you and the rabbi spoke about patients that can still express themselves, their pain, or pre-directed. What about situations where the patient is either in a coma or has a certain disease where they cannot express themselves anymore, or within the last days or hours? And I'm coming back to morphine. So you're saying that the morphine is, you both said it, is not harmful if done in a proper way, right? The patient cannot express him or herself anymore. Who decides how much of the morphine is good for the pain management, and how much to administer?
So your question is about morphine or is about MAID?
No, I'm walking away from the.
Okay.
I want to know about pain management.
So a patient who cannot express themselves and is felt to be suffering. The question of, if there's morphine could be administered and will be administered, or equivalents. Okay, there's different medications that are opioids to try to treat the pain. We have principles of prescribing medication. There's protocols that we follow. So the doctors will decide, okay, that somebody is in pain, suffering, that we could offer something to help this person. So we prescribe, just like prescribing any other things. It's part of our expertise. Okay, so it's not a blank sort of prescription. We start low, we go slow. That's our principle. Start low, go slow. It depends. Were they on morphine before? Never on morphine? Other medications? There's a whole evaluation that is taken into account here before we start. And yes.
You both agree that it doesn't speed up the process.
Who's both?
You and the rabbi, both. You both said that morphine does not, because I think the rabbi used that there's the myth of.
So the rabbi says it does. And even if we know that it does, you still do it. Halacha, Jewish law, says, that's what I quoted, the Tzitz Eliezer says, even if you know that by giving the morphine, you might shorten their life, you're still obligated to give it to relieve the suffering. What I'm saying is that this is wrong. It's true that we can do it. Halacha allows it. But on the field, right there, when I'm doing it, we don't see that. We see the opposite. Palliative care, I told you before, prolongs life. If we're able to control pain and alleviate suffering and improve their quality of life, they actually live longer. Longer. Could be days, could be weeks, could be months. Okay, there's studies that show 3-4 months more. But you know how much you can do in 3 months? When you only have a few days, imagine, left, these people have more closure, ability to do. So it's the relief of the symptoms allows for prolonged life on morphine or equivalents. Yes.
I just wanted to kind of piggyback off of what you said, just to kind of address what you were mentioning. So palliative care physicians will sort of list a protocol of medications based on a person's symptoms or signs, even if the person is comatose. And nurses, and I worked in ICU for 25 years and accompanied a lot of people through the dying process, we decide based on a range. So the nurse makes the decision based on a range that the doctor will give. So we will decide on the medication we choose and the dose based on the person's signs and symptoms. And what I would love to see, because we were talking about legalities before, what I would love to see is palliative care being consulted as soon as there is the diagnosis of a terminal illness. And that's not something that we see at all. And I really want to highlight, you're talking about mental health disorders, something like that's like, psychoneurological, like Alzheimer's, that is very much not what we see. And we should be.
Mm-hmm.
And we should
palliative
be. So
care.
I want to really highlight that. So if you know anybody, you love anybody who has a diagnosis of dementia, so that's not reversible, you got to push your providers to consult palliative care.
Yeah. So I have a slide, I can put it up, but the idea is palliative care wants to be involved as early as possible. We're not just about end of life, like I was saying at the beginning. It's not just like one phase and then you move to the other. It's a continuous phase. It's a shared care model where we get integrated to assist together with the other treatments. It happens a lot with a lot of patients, but the majority of the time it's not. And a lot of patients don't even have access to palliative care, unfortunately. And even the ones with maids. So
Somebody bring
somebody this way.
You said that before that you felt that the financial savings is not a motivation for government. What do you think the motivation for government is for the maids?
Pro-choice. It's the idea of having the choice of being able to. It's the way that it developed was because the request, because of the number of suffering, because it's population based. There is a secondary gain, okay, in terms of the cost, but it would be cruel to say that this is it, okay, and because it exists elsewhere. And it's available, it's a pro-choice, the same as abortion, the same as it's what people want. It's responding to the population.
It's also making it legal because you mentioned that before it always existed, but it was done illegally, like abortion and stuff like that. Yes. So making it legal is like to make it like
it's hard to imagine that something that was on the criminal code, that was felt to be a crime, criminal code could suddenly become. This is how beautiful our Torah is, right? Our Torah says, "Thou shalt not kill," right? We know that, 10 Commandments. You wonder, why would you need God to say that? Like, don't we know ourselves that you can't kill people if you want to live in society? Because when it says, "Thou shalt not kill," means thou shalt not kill. You cannot do it. If it comes from above, doesn't come from me, then it's a stop. You cannot go beyond. You cannot change it. I can't change and say, well, now the criminal code said, now suddenly it's not murder anymore. Now it's mercy, right? It's not murder, it's mercy. Yeah.
Sorry, I have to come back to one more point. So while
Go ahead.
I personally would, hope that I will be put in your care, right, when that moment comes, to be painless, to be as much as possible pain-free, etc. You said it more than once, I think, when you said about prolonging. And you said how much longer,
Yeah.
So from a Jewish perspective, we're not actually, by being in palliative care, we're actually not letting nature take its turn or take its course.
Yeah.
You're prolonging my living by days, weeks, maybe months in palliative care, but I don't want that. When my time has come, and I want to go in, etc. So I have a little conflict now.
So the intention is to allow nature to take its course, not to hasten death. Right?
Okay, that will correct.
We're not provoking death. We're not taking away life. Okay, this is the way that we have to understand it. We're not taking away life. Okay, this is halachically forbidden to take away life. It's considered murder. If I take out, okay. Now, palliative care wants to be able to be there, allow nature to take its course without hastening death, and without postponing it either. Okay, like it's not a question of trying to postpone death. The idea is to relieve suffering. Now, it happens. It's not intentional. It happens that people live longer when we compare. We can kill people with chemotherapy. Okay, like chemotherapy kills people every day. We think chemotherapy is going to cure the person and they're going to live longer. That's not what we see. There are people who are on their deathbed. They're still getting chemotherapy. Okay, they got it the day before they died. Okay, what killed them? The treatments. Okay, so where's the balance? How do we evaluate that? Okay, our frame of mind. This is how we think. Not doctors. I mean, people in general. There's a treatment. The treatment's going to work. I'm going to get cured. I'm going to get better. This is what we want. This is how we feel. This is doctors. This is our mission. This is what we're here for. This is what we learned. This is what we went to school for. Diagnose, treat, cure. People live, save lives. This is what we want to do. And it is a reality. And more medicine is better and better. But there's another reality that is part of it too, is that life has its end. And the way it ends will differ for different people. And sometimes we're too aggressive with our treatments as well. And that's, how do we balance the two? How do we make sure that, palliative care has a lot of competition. It's hard to think about palliative care as something that I would want. So when you're more the aggressor, somebody who's going through treatments and you're introduced palliative care, it's like, whoa. What are you telling me? I'm dying? It has that negative connotation. Okay? We used to call it supportive care to avoid this, a sort of a euphemism. More and more palliative care physicians say, no, we're palliative. We're not changing the term. We don't want to, we want people to understand what palliative care really means, and not use these kinds of euphemisms, supportive, But what your point is, you don't want to live longer. We aim towards alleviating suffering. The secondary effect is people live longer. That wasn't the intention. It just happens. Okay? Yes?
How many hospitals in Quebec offer
Every
palliative care?
hospital, every major hospital has palliative care services being integrated. Some of the smaller hospitals in the periphery may have a palliative care physician that does consultation, but they don't have an actual unit to, have patients there. But it's becoming more and more available. It's becoming a big mission, also from the government perspective, palliative care at home. Okay? Home care is, a lot of money is being injected in developing home care palliative care. Okay? And through CLSCs, it's not equal everywhere, even on the island of Montreal, but it's there. It's available and it's made available. And there are more and more hospices also, like outside of hospital, that are developing, that are being, often community themselves. They get together, communities get together, and they build it for their population. In the South Shore, we saw, communities that got together and they built a hospice to not forget and abandon our terminal ill patients, our elderly. And palliative care is also now going into the old age homes. Okay, like in Maimonides, and there's no palliative care per se, but they call us and they have to provide palliative care for their residents. This is where they're going to end their life. They have to be able to make sure that these people do not suffer through it. Yes, sorry. Yeah.
I came because about a month ago there was somebody who I'm friends with. One of my closest friends, good friend. So I know her through her. They live in Toronto. She's Jewish. She's actually from a very prominent Jewish family. She's very into Judaism. In fact, everything she does as a scholar is about Judaism. She does artwork. Everything is Judaism. She died of AIDS about less than a month ago. And my good friend, she recorded. She was with her when she died, and she recorded everything that went on. And it still sticks in my head because I'm very close with her, and she let me hear the night before. And when the doctor came in that morning at 9 o'clock, it was set. He rang the doorbell, came in, gave the injection. She was there holding her. Her son was there holding her. But it wasn't like you said, somebody asked, what would the other doctor say? And they promoted it like it was something. She signed up for me 2 years ago. And she's somebody who is terminally ill. She's somebody, she's somebody who has suffered for as long as I know her in pain. She wasn't able to be upright. She had a lot of medical conditions. She stuck through years and years. And 2 years ago, she went through everything. She spoke to rabbis. She spoke to a million people who tried to, dissuade her from going forward with it. And she herself didn't want to go forward with it. Then she decided, okay, I'm going to do everything while I'm sane and while I'm able to do it. And she got everything done 2 years ago. The night before she did it, my friend was there with her, and she just couldn't take it anymore. And she said, "Mate," and that's what it was. The morning they came in. But the doctor, even when the doctor came in to administer, he asked at least 5 times. I heard it. Are you sure? Is this what you want? There are other options. So maybe not every doctor is the same. And I know that you said like what your colleagues will say, and I believe that everybody's person, the day they are born and the day they die is already written. And we know that God knows that. And that's just my belief. I don't know if this is going against that, but I just felt that the way it was done was a little bit different than what we're doing here, that the doctors are selling it.
No, so I don't want to get I didn't want to mean to say that they're selling it.
I was shocked.
No, but doctors are not selling MAID. Okay, that's not what I wanted to say. Okay, I'm saying when it happened and they present it, okay, it's a celebration of life. Okay, the scene is often it's attractive, but we're not selling it. Okay, we're trying to sell palliative care, yes. Okay, sometimes we have to convince patients to want to follow. But yes. So talking about my colleagues, we're not going around looking for clients for MAIDs. Okay, it comes from the patient. Okay, it goes through a system through the hospital, and then the doctors are called in to make their evaluation to see if yes or no they're a candidate. They go through the questioning. Are you sure this is what you want? There's a whole process, questions that they have to ask. It's not a given right away. And it doesn't have to be right away. They can write a date. I want it in 3 months, or I just want to know if I'm a candidate, if ever. But it's not promoted in the sense that, well, you have a terminal illness. Do you want MAID? We don't do that. Okay, nobody does that. Nobody says you're going to die soon. Do you prefer MAID over? Nobody does that. Okay? Not nobody that I know does that. Okay, not in our hospital. Okay. Right. No, but what you're saying is that there's a lot of suffering out there. There is a lot of suffering out there for different reasons, whether it be from medical illness or for other reasons. There is a lot of suffering out there. And how to fathom and be able to support and go and live through that suffering. Everybody has suffering, whether it be at home, with different reasons. I'm suffering with my children, I'm suffering with this, I'm suffering. Okay, but there's a lot of suffering out there. People with illness, chronic illness, do suffer. I mean, if you have other questions, I can answer them. I wanted to end with a story, which is an interesting. It's a Torah story. It's a midrash, but I'll take your questions first.
You said there's two stages. The secondary stage where they're not terminally ill and would benefit from palliative care, but is palliative care only available in the hospital?
No.
Because I don't know. My aunt, as an example, is
So-
somebody who could benefit from it, and she has no way of getting access to it.
So palliative care is accessible, okay? But how do we access? So anybody can ask for palliative care, first of all, okay? It could be through somebody at home, CLSC. That's what people don't know, okay? The tragic part of the story is that the services are there, money is being injected, but access to palliative care is only about 13 to 20%, okay? For the population who would need it, only about 13 to 20% of the population that would need it really have access to it. Often through the hospitals when they're in, and even when they get access to it in a hospital like ours, it happens to be far advanced, later than when we would have wanted to be involved. Say, oh, how come nobody called us before? How many times do we, think like that? We're saying, we could have been involved already, much weeks and months prior to this. So it's out there. It's available through CLSCs in hospitals, outpatients. I have colleagues. We're integrating ourselves in order to be closer, in the outpatient clinic. So in oncology specifically, where the hospital is a big oncology place.
What advice would you give for someone who is concerned that perhaps towards the end of their life they'll lose the capacity to make decisions, and then it's going to be left in the hands of family or a doctor, and they want to ensure that their end of life will be according to Torah? What should they do now?
Okay, very good.
Living will.
So what is permissible? Your question is what is permissible, halachically speaking, okay, in terms of
and legally.
Legally, there's no problem legally, because there's no law that would, sort of. I mean, we go certain ethics, and in a hospital, a lot of things get done because of what patients want. So it's based on autonomy.
What if the patient is in a position that they cannot guide?
So they
They
cannot
fall
guide.
suddenly ill, and
So it's a good thing to have a living will. It's a good thing to have a living will. It's a good thing to say in writing what it is that you would want your care to be like. Okay. Now there is such a thing as a halachic living will. Okay, we're amongst Jews, so living wills exist. You go to your notary.
I have copies.
Many times you go to the notary, and the information there is only about 3 lines. Okay, so a lot of times the information there doesn't really help us because it's only about 3 lines. It's not enough. We have created a living will at the Jewish hospital. Dr. Dworkin, you might have heard his name. He was very big on the living will project. He was a palliative care physician like myself and a family physician. Retired not so long ago. And for years, he wanted to put together, and he did, put a living will document. And there is one available through the Jewish General Hospital. It's not a legal document. You don't have to go to a notary, but it still holds. If it's written, you've written your directive, your wishes, and you give it to somebody. You can name a mandate. It doesn't have to go through any notary or any legal process. It would hold, okay? And in there, the advantage is it gives different scenarios. If I have Alzheimer's, or if I have cancer, or if I have this, or I have that, I don't want this, I don't want that, I want that. Usually, people are allowed, halachically speaking, to not want certain things given. Withholding certain treatments is allowed. Okay?
Supposing I was thinking, I'm not.
Supposing you were thinking, okay.
I was doing a living will, and I wanted to say if I get very ill, what I want made.
Yeah.
But I wouldn't want it to follow me that 30 years from now, when their kids are ready to bury me, they're going to look and say, "Oh, she said she wanted made."
So that scenario exists today, right? But I don't understand your question. Like if you like, Rabbi, you brought a situation of somebody who's Alzheimer's had written that they don't want made, that he wanted made if I was Alzheimer's, but they're happy. Let's say, relatively speaking, their quality of life is acceptable. Now, who are we to judge on somebody else's quality of life? That person may not be able to judge themselves because they don't have the conscience for it, if they're Alzheimer's and very advanced, but they're being taken care of. They're enjoying life.
So if you write down made in a living will,
Yeah.
you get it whether you want it or not.
No, but it's not. I mean, it would have to be organized by somebody, right? It would have to be organized by maybe the children, or that, okay, my mother wrote this, so bring it to the doctor who administers the maid. But what you're saying is it's true. It doesn't make sense, right? It doesn't make sense. But it does exist. That scenario does exist. How do you implement it is your question. I don't know, right? I don't know. There's gonna be conflicts between maybe family members and who's gonna decide. I mean, we have this problem today. Not everybody has a living will, and situations like you described, somebody in ICU, they can't answer for themselves, or they have advanced Alzheimer's, or they had a stroke. Chas v'shalom, somebody has a stroke, ends up in the emergency room, and we think they're going to die. They don't die. What happens? You want to feed them. You can't feed them. You got to put a tube to feed them. Do we peg or do we not peg? Who do we ask? There's no living will, no advance directive. If there was an advance directive, maybe they would have said, I don't want to have a feeding tube. Or maybe they would have said, I want a feeding tube. So it's easy to follow. But that's it. So this happens all the time. This happens every day.
My father said never a feeding tube, and we have to make the decision that we can't let him die.
So halachically speaking, okay, maybe that's why Rabbi you got up. Were you going to talk about that?
What was the question?
Feeding tubes. Halachically speaking, okay, we're amongst Jews. Halachically speaking, we cannot deny feeding to anybody. Okay? So even if a Jew writes, I don't want feeding tube, okay, we are obliged to give him to feed, even if it's artificial. Now, can we do that in our day and age, in Montreal or North America, where everything is based on autonomy, and you're going to have a lot of dissenting opinions amongst the families? So we can't impose, but principle, yes, we would have to put a feeding tube, even if they wrote no. Okay, this is Jewish law.
Exactly, this is where the thin line is between prolonging life and putting someone, let's say, on a machine or whatever, which is, terrible, and quality of life, or saying here, I cannot let my father starve to death, even if he would not want it or he doesn't want it, but the two kept him alive. Okay, another 3, 4, 5 days, but I can't let him starve. I can't watch him die from him.
Yeah, but that's a dilemma. It's an ethical issue that comes up every single day. Okay, somebody can write in their living will, I don't want to be intubated. Halachically speaking, you can write that. You're allowed to not be intubated. We don't have to intubate. We can withhold. But if you're intubated, can't remove it. If you're dependent on a ventilator and you're plugged on a ventilator, I cannot remove it, because if I remove it, I'm taking away life. If I know that the person will die, then I'm doing an act of removing life. And no, well, exactly. A feeding tube is in place, I can remove it, but I have to put it in. Whereas a respirator, I don't have to start somebody on a respirator if there's reasons to avoid it. So there's things that we can withhold. Withdrawing is different. If we look at how general ethics, secular ethics, look at these problems, withholding and withdrawing, they're two different things. For us, for them, they're equal. So if I take somebody off a respirator, or if we withhold it, it's the same. Ethically speaking, secular ethics, withholding and withdrawing, equal. Jewish law, no. Withholding, I'm allowed in certain situations, but you cannot withdraw. Okay, you cannot withdraw, and there's definitions as to what it means to withdraw in which situations. But somebody who's on a respirator, I cannot unplug them. If I know that by doing so they're going to die, that would be taking away life. I'm not allowed to take away life. That would be considered murder. Okay? A DNR is allowed. Okay, is allowed. We can change. We talk about levels of care, A, B, C, Ds. Okay, those are things are allowed. By the way, palliative care, I have a kippah on my head, and I told that to the rabbi before. When I first started doing palliative care, it was a dilemma of my own. Is this halachically okay, what I'm doing? Okay, because of morphine, because of this, because of that. You know, like life at all costs. This is what Jewish law says. Save a life is the number one mitzvah, trumps everything, right? You can eat on Yom Kippur. You have to eat on Yom Kippur. You have to save a life. Shabbat, anything, right? Gets trumped by sanctity of life, but to save a life, everything. Okay? So if I allow somebody to die, am I going against that principle? And of course, Baruch Hashem, I found out and discovered through reading and studying that palliative care, there's all protocols, care of the terminally ill, a huge book written by Rabbi Moishe Feinstein, who was in the USA, as everybody must have heard his name, and others in Israel, Rav Shlomo Zalman Auerbach. There's Professor Steinberg, who's written a lot about it. So all end-of-life care is not only halachically permissible, it's obligatory. Okay, it's obligatory. So, yeah, one more question.
We need to.
How sure?
Insurance companies accept MAID, no problem.
We'll wrap it up, and people can hang around if they wish.
One more question.
I had an aunt who had Alzheimer, and children decided to put her tube, okay, to live longer. But she lasted, I think, 5 years in the tube.
Yeah.
She was gone, completely gone.
Yeah.
Can we say that the Neshama left her?
Yes. When?
Before?
No.
When she was not there.
No, you made a mitzvah. You saved her life. She lived longer and she died.
No, but she was not there.
She would have died earlier had we not done that. But you did what you had to do is to save her life. So, halachically speaking, it's good.
Okay.
But yes,
you see her,
I understand. So what we're trying now, we're talking about quality of life, right? Now you're bringing up.
Can we say that the Neshama left her?
No,
We're gonna close here,
no.
folks. I want you to know that Montreal. Thank you, doctor. First of all, a big yasher koyach.
I want to finish my story. I guess it's a Dvar Torah at the same time. Okay, so I just want. There's a lot of suffering out there, and you brought up the issue of suffering, and it made me think about this midrash that you probably know. There's a very, very beautiful midrash. I want to finish on this. It means a lot. I mean, we could spend a lot of time talking about it. There's a concept in the Torah that when a word comes up for the first time, it means it's the first time that it happens. Okay, there's a concept like that. Okay, in the Gemara that says the first time that something appears in the Bible, that means it's the first time that it actually happens. Okay, and it says that for Yaakov Avinu. Okay, we're going to read very soon that Jacob became sick at the end of his life. He was chole. It's the first time that this word comes up. So it's the first, that means he was the first sick person. Okay, people were dying, of course. Okay, but they were dying of some other things. We know, like Gesundheit, right? Somebody who sneezes, neshama leaves their that's what we say, Gesundheit, and like Chaim Tovim in Hebrew. Okay, but the first person who was sick was Jacob. Now, all our three avot, Abraham, Yitzchak, and Yaakov, each of them had something special that was the first time. It says, Ve'Avraham zaken babayami. Okay, first time that the word old, zaken, appears is for Avraham Avinu. Avraham zaken, he was old and older in days. The same thing with Isaac, Yitzchak. It says he was, he had problem with his eyes. He had, a condition with his eyes. It wasn't considered to be an illness, but he had this situation. Now the Midrash says like this. Okay? Before Abraham, there was no old people. Elderly people looked alike. Okay, and that's one of the things that we say is that his son looked exactly like him. He says. So he went to Hashem and he says, the Midrash says like this. Do something, because how can we recognize that somebody has more years than their children? Like, there has to be something special that we could be able to recognize, that somebody has the wisdom, certain, that they're advanced in age. Apparently, there was no such thing as being elderly. So he asked that to Hashem, and he said, okay, that's a good thing that you asked, and we'll start with you. And that's how it became Avraham Zaken Baba Yamim, because he was the first one to ask. Hashem said, it's a good thing. I'll skip to Yaakov. Okay, the same thing. Yaakov says, it's not normal that people just leave this world just like that. Why don't you, create something that makes sense, that maybe somebody can have time to prepare themselves, like suddenly you pass away, like you didn't give time to your family. There's something wrong with that. Something you have to, we have to find a way. You have to find a way to make, that somebody knows perhaps when their last days are coming, so that it's not so sudden, and we know some of the benefits that might bring. So he asked that of God, and God says, it's a good thing that you asked for, and it will start with you. Now, Isaac did the same thing, and he asked, what did he ask for? So he asked for old age. Abraham asked for old age. He asked for sickness. Okay, he said, why don't you make the person sick? It's not that it invented. They asked for it. Okay, it's considered the gifts of to humanity that God gave to humanity. He asked for old age. Jacob asked for illness, so that the person could know, they have a sign, they have a way to know that they're in. Isaac asked for suffering. Isaac asked for suffering. Isaac is the Gibor, he's like the Gvura, he's Midat Adin, so and he asked for suffering. And when he asked for suffering, his argument, it's hard to say, I don't have it in front of me, remember the words, but again, it was something that was missing. And when he asked God, and he said, a person's merits, a person who lives here, they need to have certain values, certain merit. If you give him suffering, perhaps you can increase in the merit. And Hashem said, it's a good thing that you asked for, and it would start with you. The reason I'm finishing on this is because we talked about the suffering, and of course, who wants to suffer? Who wants old age? Like we say, old age is not for sissies, right? I mean, there's a lot of things that come with it. At the time, old age didn't come with the suffering. It was just a visual thing, right? A bit of gray hair, a little bit of wrinkles, just so that we can see, the age on somebody, can differentiate between the young and the older, and the respect that comes with that. The same thing with the end of life, sick, organizing yourself, making sure that the family is prepared, everybody's prepared for the end of life. But suffering, how can Isaac ask for suffering? But God says it's a good thing. So there's something good that we have to discover in each of those things. There's a good part to it. There's a benefit to it. There's a value to it. And I think that's what you were trying to say before. It's left to us to discover, basically. Thank you.
But the final, Thank you, Doctor. Now let us remember, dear friends, that the final chapter and the objective of purpose of life, and we stand on the threshold, is Mashiach's coming, and then all illness is eradicated, death is eradicated, life eternal, souls in bodies, even souls that are passed on, heaven on earth forever. That's the ultimate. So although everything that has happened till then, even suffering, has its purpose, it's temporary, not the end goal. The end goal is no suffering and no death and redemption personally and collectively. One more thing, I want you also to know that our city is graced. Rabbi Binyamin Yonason Weiss, the head of the Vada Ir, is a world expert on halacha and medical ethics. All to say, God bless everybody with long life, never have any issues. But if you have a problem, you can call me. If I have the answer, I will guide you. Not you consult with him. There are answers. Torah is compassionate. Torah is all about life. And Torah is all about the best for you. May God bless us all with long life and nachas and health and Mashiach now. Thank you all for coming.